Hello, everyone, and welcome to the Bale-Donene Method with Dr. Gina Pritchard. Today, I'm here with Dr. Pierre Leimgruber, an interventional cardiologist from Spokane, Washington. And Dr. Leimgruber, I'm thrilled that you've joined us today, and I am very pleased to let everyone hear the information that you shared with us a couple of years ago in New Orleans at the Bale-Donene Method reunion. And it's important information as well as a very interesting story. So thank you so much for joining us today.
Thank you, Gina. It's a pleasure to be able to talk to you and the audience about my history. How do I, went through all those years, and how did I end up in Spokane, Washington, and how fortunate I am right now to work with Dr. Amy Donene and Dr. Bradley Bale. So before we get to the end here, I want to start where I was born and raised. I'm originally from Switzerland. I was born many years ago. As you can see on this picture, we were a family of 7, mom, dad, and I have 4 siblings. I was the last one on the bunch. I was about 5 years of age. We had a wonderful upbringing. We lived in a small little house that my dad rented. He worked for a big aluminum company, and they provided the housing. My mom was a seamstress, and all my siblings were a little bit older. I was the last one to come along. I want to share you something else as well, as you can see in this next slide here. And my dad, he had problems with his heart. My mom died also from a heart problem. My sister has heart problems. She's alive and well. My oldest brother, Joseph, he has also heart issues. My middle brother, Felix, he died of a heart-related problem. Victor doesn't have a heart issue, but he has vascular disease. And I myself, I have some very strong history. As you can tell, family history lives very much in our family. And is it a surprise that I'm a cardiologist? Possibly not. Anyhow, I went to all the schools in Switzerland, and then I graduated from Zurich, Switzerland school in 1977. And that's I finished all my training in Switzerland, and in that moment I decided to jump over the big ocean and then come to the United States.
So since graduating from medical school in 1977, I know that was about 10 years or a little more before coronary stents and balloon angioplasty took off, but certainly it was being investigated heavily in animal studies probably. Nonetheless, I'm very interested to know, how is it that you went from medical school graduation in 1977 in Switzerland to becoming the esteemed cardiologist, opening up blockages without bypass surgery in the United States? Tell us that story.
You're right. So in 1977, it turns out, the year that I graduated, it was the year that Dr. Andreas Grünzig did the first coronary balloon angioplasty. You see here Dr. Grünzig with his balloon. That was in one of the the popular magazine in Zurich that he was featured. And that was the year that I graduated and then decided to come to the United States. This is a picture of that very first patient that was done in 1977. What you see is an angiogram with those coronary arteries. You see a blockage here. The same blockage is once again displayed. And you can see here in this particular photograph that how the balloon was inflated. It was a long, like a balloon, like a sausage. And then after the balloon was deflated, you see how that blockage is completely disappear. Blockage before, blockage afterwards. What you have here is like pressure recordings. So that was a very important year, 1977, when Dr. Grünzig did that. Now, in terms of the history, how did he just didn't invent this overnight. It is a long, long history that led to this invention of the balloon angioplasty. And as a matter of fact, the real granddaddy of intervention is this fellow, Dr. Charles Darter, who practiced at OHSU in Portland, who had actually published many, many years before. In fact, in 1964, Dr. Charles T. Darter published in Circulation that he had figured out a procedure how we can open up blocked leg arteries with a special catheter and that catheter allowed him to reestablish flow in people who would have lost their leg and would have needed an amputation. This procedure, unfortunately, didn't really take roots in the United States. And in fact, Dr. Zeitler from the United States, that procedure came to Europe. Dr. Zeitler was a radiologist. Dr. Grünzig was his fellow. He learned from him. So he went to Europe. In Europe, Dr. Grünzig here now featured with Dr. Dauder, Charlie Dauder, that started in 1964, ultimately lead to the development of a balloon that Dr. Grünzig personally pushed forward. His idea was to open up arteries, but not with a catheter like Dr. Dauder did, but with a small little balloon. In fact, this was one of his first rendition of how he thought we could tie a piece of plastic at the end of a tube, and he kind of with a little lighter, burned it off so there was not air escaping, and then there was a little slit there. So he tried multiple different reiteration of how he ended up with the balloon. And here's a schematic picture of how balloon angioplasty works. You have an artery here that's blocked. You have a little soft, very soft wire that gently crosses it because it's flexible. It doesn't do any damage. And then you follow up with a catheter. The catheter is then positioned right here. It turns out that's where the balloon is. The balloon gets inflated, and then the balloon gets deflated. And as you take everything out, you see that blockage that was right here, that stenosis, as we call it as well, has now completely opened up. That's the Grünzig procedure that he did in 1977. This was one of his first associate, Maria Schlumpf, and they literally manufactured those first balloons on the kitchen table with lots of PVC tubing and glue and super glue, and of course a good bottle of Swiss wine as well. This happens to be the very first patient, Adolf Bachmann. He was 37 years old or so, 1 week after he had his coronary artery blockage fixed, which was unbelievable at the time, because if you had to have a coronary artery fixed, you were in the hospital for about at least 3 weeks. Then you had to go to rehab another 3 weeks. You wouldn't go swim a week later. So I just want to show you that picture of this very first patient, Adolf Bachmann. So I graduated in 1977, as I told you several times now, but then I moved to the United States. I realized that the training in the United States is extremely well developed. It's very structured and it's easy to learn. You go to a certain process, and I ended up in Flint, Michigan. Of course, now everybody knows about Flint, Michigan these days. Back then, Flint was only known for his big GM factory plants. I went then to Detroit, where I did my internal medicine training. You have to be an internist before you can become a cardiologist, and I did that in those 3 years. Later on, then I moved to Milwaukee, Wisconsin, where I worked at the medical college from 1983 to 85. In 1983, I was ready to leave my training and start, supporting my family. At that time, we had three children, and so money was in short supply, and I was ready to become a regular cardiologist when I learned that Dr. Grünzig actually moved from Zurich, Switzerland to Atlanta, Georgia, where he worked at the Emory University. And I had this idea that I should see if I could work with him as a fellow. And of course, I envisioned piles and piles of fellows who wanted to apply, and they all get denied. And I figured out, what if I write him a letter in German? Then there's a good chance that if I write it in German, he will have to read it. So his secretary just won't put it in the pile of denials. And lo and behold, he ends up calling me at home, and they told me, yeah, if you want to come on down, I'll work with you, and the rest is history. So Dr. Grünzig really gave me a job, and I worked with him at Atlanta Emory University from 83 to 85. Well, there he is at Emory University. Unfortunately, as you can see, he died very young at age 46. Dr. Grünzig also was he was very supportive of his people. This is a picture at Christmas. He opened up his big, mansion, a typical southern, United States, Southern Georgia mansion with all the children of all the employees were invited. Santa Claus came, and we were singing some Christmas carols at the end of that evening. I was also very fortunate that I was able to excuse me here, to publish a lot of research at that time, since it was all new. But then, as I told you, Dr. Grünzig died young on October 27, 1985. He was a pilot that he loved so much, and unfortunately, he died in a plane crash, him and his wife both together. It was in 1985. Very tragic, because 1985 is also a year that we lost three other pioneers in cardiovascular care. One is Dr. Judkins. Dr. Judkins was a radiologist who, until this day, we use his catheters to do an angiogram. Of course, Dr. Grünzig, who you know now, is Dr. Mason Sones, who did the first coronary angiogram injecting dye into a coronary artery in October 30th, 1958. And of course, here's Dr. Charlie Dodd. It's just very bizarre that all of those four guys died in the same year of 1985, but that is what happened.
Wow. Dr. Leimgruber, so when Dr. Grünzig died in 1985, tell us the story from that point to your moving to Spokane, Washington. How is it that you decided to move to Spokane, Washington, and what makes Spokane so special?
There you go. Okay, thank you. Yeah. So here it is, when you are a fellow, you look for jobs, and usually is next to the main cardiology office, there's a poster, and people who request a trained fellow to join them, they post those letters and request, and you read them, and you see if something is there. And I saw a letter from Dr. Shields' group in Spokane, a cardiology group, and they were looking for a fellow that's trained how to do balloon angioplasty. So that's where I went, from Emory University to Spokane, Washington. And as you appropriately asked, why Spokane? I think I need to give you a little background as to why Spokane was intriguing to me to go there. And I saw the ad, I said, Spokane. Isn't Spokane where they did the heart surgery for many, many years? And yes, indeed, they did. And in fact, the first heart surgery was done on June 6 in 1952. It was a patient by the name of Barbara Envold. She's now long dead, of course. They did a closed mitral commissurotomy. In other words, they worked on a beating heart they didn't have any heart-lung machine at that time. So the procedure that was done by Dr. Ralph Berg, he was a heart surgeon, born and raised in Spokane, trained at Mayo Clinic, came back to Spokane and became then the preeminent heart surgeon. This is the procedure that they did in 1952. You see Dr. Berg sticks his finger across the mitral valve that's narrowed because of rheumatic fever. The heart is still beating. He has a little string or a tourniquet around where he sticks his finger so the blood wouldn't just gush out. And as the heart was beating, he quickly opens up that valve with his finger, and that's used to be called a closed commissurotomy, because that did not require an open heart machine. This is Dr. Berg, as he did surgery in the 50s and in the 60s with his assistant there in the operating room. And Dr. Berg also was working on the first heart-lung machine that was developed in the late 1950s. This is one of those prototypes of a heart-lung machine where you can actually stop the heart beating. You can stop the lungs from having to require oxygen, and you artificially provide the oxygen into the bloodstream with this heart-lung machine that takes over, and then the heart is very quiet and you can operate on the heart. He was very successful, Dr. Berg, and in fact, in 1959, January 10th, so we just had a 60th anniversary for the first open heart surgery that was done in a 39-year-old lady. And here's the first operative report. You can see January 10, 1959, Dr. Berg, Cleveland, Kaufman Lang, Sister Mark, and support, and Betty Larson was one of the person that helped him. Repair of an atrial septal defect through right thoracotomy with bypass and open heart surgery. Surgery started at 10:30 and lasted till 4:30. See, 6 hours of surgery. Nowadays, the same procedure probably will take about 45 minutes to do. And so it was the very first, they were very successful. In fact, this is Dr. Berg, 1972. that this picture was taken. He was also an avid hunter. And this is my partner, Dr. Paul Shields, who in 1961 arrived in Spokane as the first cardiologist in the city. Dr. Shields is absolutely a pioneer. I'm a big fan of Dr. Shields. He's still alive. He just had his 90th birthday last month. And he back in the, even in 1970s, he was convinced that atherosclerosis is not just deposit of fat. It's actually an inflammatory process. I also want to tell you that Dr. Shields in 1966 did the first coronary angiogram. You remember the first coronary angiogram in the world was done in 1958. So 8 years later, he did his first one at Deaconess Medical Center. It wasn't just the first one in Spokane, it was the first coronary angiogram that was ever done in the state of Washington. Seattle, they didn't do any coronary angiogram at times. Spokane was that place where they start really advancing cardiovascular care, thanks to people like Dr. Berg and Dr. Shields. I knew about those people. They published information. That's why Spokane for me had a ring to it. I mean, I wanted to explore it. I want to see, is it really that good as they claim? As a matter of fact, they published important information. I'm going to move this a little bit here for you guys. So they published acute myocardial infarction is a surgical emergency, or a heart attack is a surgical emergency. In fact, they operated on a patient that had a heart attack. The first one was done in 1971. And at that time, people were thinking, this has got to be malpractice. How can you take a patient with a heart attack into surgery? That's highly unorthodox. Nobody was daring doing that. The surgeons were so good that they were actually able to do that. And they published their 1 year mortality, that was, let's see here, I'm going to see that. The 1 year mortality with not doing a bypass at that time was 30%. A third of the people died. Once you had a heart attack, you had about a 1 in 3 chances of making it, okay? Now, if you did surgery, look at that. The 1 year mortality was 6.3%. Look at the difference. So heart surgery was, in their hands, in Spokane, highly effective, okay? So I just wanted to see if I can move that here again to the side here. Anyhow, so that's what was happening in Spokane. They did emergency heart surgery. I knew about it. I wanted to first find out, is it really true what they do? Okay, and in fact, this is the article that was published in 1980 in the New England Journal of Medicine, which really made a tremendous impact in the entire world, because the surgeons and the cardiologists in Spokane were identifying a clot that was removed with a small little balloon catheter out of the arteries of patients who came into the hospital with a heart attack. Okay, so that's what happened in Spokane. I liked what I saw. I was convinced those guys are the real deal. And it's not just some kind of fly-by-night group that does some crazy stuff. And so I joined Dr. Shields' group, and I worked with balloon angioplasty, of course, and then later on we had laser, we had other devices that we tried to open up, and of course in 93, then the coronary stents were developed. And this is what a coronary stent looks like. It's like a metal mesh, like a scaffold that is put inside the artery to keep the artery open. The balloon was able to open up the arteries, but often the artery would collapse, and then you had an emergency that you would have to then fix with a bypass, which was always very traumatic. Since stent came around, that rarely happened that you had to take a patient to surgery. I'm going to show you the very first patient that had a coronary stent in 1987 that was still experimental, that was done at Emory. You see an artery that was really badly blocked, and then they did a balloon, and it really opened up a little bit, but not very well, and you can then see how this artery completely just collapsed. And that patient, 15 minutes after the procedure, has chest pain, he has EKG changes, as called as ST, segment elevation. And at that point, up to 1987, that patient would have been rushed to the operating room, an emergency sternotomy, where you have to enter the bones in the front of your chest and do a bypass, okay? Well, guess what they did? They were able to refine a small little wire through the blockage. They put the stent in there, and look at how nicely the artery after the GR stent, giant Rubin stent was the name of that very first bailout stent that was actually used in the first patient. So another thing that happened in Spokane was the development of coronary artery calcium test, or coronary artery scoring, CAC score, for coronary artery disease. Our group, Dr. Shields, together with the radiologist, purchased the first ultra-fast CT scanner that allowed us to look at coronary arteries and look and see if the patient has calcification in their arteries. And this was a breakthrough because we could look into the heart without doing an angiogram. And this is the abstract that I was able to publish in the American Journal of Cardiology in 1993. And the big supporters of coronary artery calcium score was Dr. Byron, Dr. Paul Shields, of course, my group. I put all this information together. There's another two colleagues of mine. What we were able to show, and I'm not sure I can move this here, but that's okay. Okay, here it is. Let's put it a little bit out of the way here. What we're able to show is that this is a group of patients who had normal arteries. This had mild coronary disease. They had one vessel disease, two vessel, and three vessel disease, where all three arteries were blocked. In the white column, you see the calcium score. In the little hashed area, you see how many lesions were identified. And it's not surprising that the more blockage you have, the more calcium you will have, in the heart arteries. But look at this group here. Those were normal coronary arteries. We found that about in that group, the calcium score was close to 100, and we found about 5-6 lesions in those people. We thought they had normal arteries, and this was my last comment there in 1993. Coronary artery calcification in patients with normal coronary angiograms may suggest earliest manifestation of coronary artery disease. Okay, so I want to show you what happened. Those individuals listed here were only a few of the folks who used coronary CT scanning in Washington, in Spokane, Washington at that time. And another doctor was Dr. Bradley Bale. He immediately realized, Dr. Bale was working as a primary care physician at that time in Spokane, and he realized the importance of a coronary artery calcium score in demonstrating subclinical, that means the earliest findings of atherosclerosis, of plaque buildup in the heart arteries. And he immediately realized its value by using this in patients in order to prevent heart attack and stroke, by giving them the earliest intervention, the earliest recommendation as far as the cholesterol, weight, and so forth. And of course, you all know Dr. Bradley Bale. That's why it's called the Bale-Donin method. But that happened in Spokane because we had a coronary calcium score. That was the first way that we can look inside the patient's arteries. Nowadays we do a bit carotid IMT scan, but coronary calcium score actually preceded that way back then. Okay, so after that, I also worked on carotid stents, where we have blockages in the carotid artery. You can see this is a main common carotid artery. It is the artery that goes into the brain. That patient will be at risk for a stroke. And we were able to actually open those blockages with a long stent that we placed right across that blockage. And at the end, the artery was wide open, as you can see. And that was an exciting time for me because I was fortunate enough that I was able to participate in nationally well-known journals like the New England Journal, in publications that talked about the importance of carotid stenting. In 1997, there was this particular headline. It says, "Is cardiology flatlining?" Mostly talking about how there was nothing new being developed. I mean, we seem to get to a point, where progress was really slow. Of course, it has since progressed again. And then, everybody thought that we should really look into public health. And that is kind of where I made some critical decision at that time what to do next.
Dr. Leimgruber, that history, even though it's the second time I've heard you present it, is so incredibly interesting to me. And you're right, over the relatively short period of time, the medical advances that were made and the refinement of the procedures and the tools used to carry out the procedure, just amazing. And it continues to be life-saving, certainly in the heart attack arena today. When someone presents to the hospital with a heart attack, certainly you want a cardiologist such as yourself that's an interventionalist, well-trained, that and a team around that person that knows exactly what to do, because taking someone to the cardiac catheterization laboratory and getting that blockage opened up, as you've shown us on these slides, is what will save that person's life today. So it has saved a lot of lives, that's for sure. Extension of life is another thing, and quality of life is another thing. But anyway, I digress. I love this history. I love this story. Love to hear more from you. But my question now revolves around your transition, if you will. You know, in case those individuals listening to us don't really understand the cardiology training, a general cardiologist, if you will, sees patients in the clinical setting. One that takes an additional amount of training can do the diagnostic procedure of cardiac catheterization or coronary angiography, where dye is injected into the heart, like these pictures you've showed us today, to diagnose a blockage that may or may not need a stent. And then an additional fellowship of 2 to 3 years, I believe you'll tell us, is required to become what's called an interventional cardiologist, which you've had a long and respected and just an esteemed career as an interventional cardiologist, not only advancing the technology, but performing life-saving procedures on thousands of patients. That was your life every day for years. So tell us how you made the decision. Maybe it was quick, maybe it was a slow process to go from interventionalist to your current practice, which is totally a preventionalist, if you will.
Absolutely. So I'm glad you asked me that question. Obviously, exactly. I went from intervention to prevention, or from, as Dr. Amy likes to say, from luminology to arteriology, and so that's what happened when I joined Dr. Amy Doneen in April of 2017. In a heart attack and stroke prevention center. I just want to show you in that same year of 2017, here's the Adolf Bachmann. Adolf Bachmann is now 40 years later, still alive, and he never had anything, no bypass surgery. He had that very first balloon. My wife and I were fortunate to attend that celebration, the anniversary in Zurich, Switzerland, as one would expect to celebrate the 40-year anniversary. I also want to show you, before we get into the prevention field, a couple of slides which are dear to me. Those are my 5 children. This is fishing in Alaska in 2011. My youngest daughter is now a CRNA. I got a couple of lawyers here. There's a kindergarten teacher, and one works for Caterpillar. They're all doing wonderful. I'm very blessed in that. And this is my latest addition. This is my little Wyatt, as my grandson, the 21 months old. It was done like a week ago with his fireman suit in Brooklyn, New York. Now here we have another picture that you all are familiar with, Dr. Bale, Dr. Amy Doneen, and then we have Dr. Paul Shields, also in 2017, excuse me, where we had a reunion, the 3 of us. Dr. Bale knows Dr. Shields very well, and vice versa. We had a wonderful evening. I just want to show you this picture here, and then I can tell you in terms of where we are with the transition into. So maybe, okay, if I can bring this up. Okay, is that okay for you? Does that work? Or how should we do this?
That's absolutely fine, yes.
We can, all right. Oh, is there any way we can do you all see the big, okay, so there we go. So I'll tell you what happened is, why did I switch from intervention to prevention, is what was your question, right, Gina? I want to go back to that. And the reason is actually quite simple. Dr. Amy asked me if I would like to join her in her practice. So that was a tremendous opportunity for me, and to work in the prevention field. So how did Amy do that to me? Well, I tell you why. You know, when I had my triple bypass surgery in 1996, I started with Dr. Brad Bale, and then later on Dr. Amy Duneen. So I was intimately familiar with the Bale-Duneen method. I knew it would work. I was fortunately enough, and to this day, I'm fortunate enough to benefit from that in a big way. So for me, the decision was not, well, what's up with this Bale-Duneen. I knew what was up with it. It does work. I was personally benefiting from the Bale-Duneen procedure, and so that is why when she offered me the job, I quit my interventional cardiology job and I completely focused on prevention. I also realized, Gina, that in order to make an impact, we have to start with the prevention. It's wonderful, all the things we can do with stents and balloons and, emergency bypass and valves and so forth. But ultimately, it would make a lot more sense, if we can prevent this from happening. So that is why I felt I need to grab this opportunity. Yes, I'll have to learn quite a bit more. The prevention is a field that requires a lot of knowledge and a lot of teaching and coaching and monitoring and investigation, and that intrigued me, and that's why I made the switch from intervention to prevention.
So, Dr. Leimgruber, you first started seeking out prevention for yourself after you had a bypass surgery in 1996.
1996,
Wow.
that is correct. Dr. Bale was practicing. That was before Amy joined him, and then as Dr. Bale was called to Texas, to the faculty there, and that's when I continued with Amy.
Nice.
Ever since then. Correct. Yeah.
Wow. So you had personal experience before deciding to make a career change.
Absolutely. Well, I mean, I was ready to make a change. But then as this offer showed up, then I said, this is really what it's all about. I was able to continue to help people at the beginning as opposed to at the end of their process. And that's what really got me fascinated and interested. Correct.
So I know in the hospital setting, those listening who work in the emergency room or the Cardiac Catheterization Laboratory or even the OR, there is somewhat of a adrenaline rush, or it's a very exciting job when someone comes to the emergency room near death or perhaps with sudden cardiac death, the worst presentation of a heart attack, if you will, or even just, excruciating chest pain, and you see there's no blood flow and it opens up and, everybody's thrilled because you've saved a life, right? Saved cardiac muscle, and it's very exciting. So if you would compare and contrast your job as an interventionalist to that as a preventionalist, and do you like your new job? I mean, just bottom line, tell us, are you loving it, or how's it going?
Absolutely. It's a very good question. And believe me, it wasn't easy to make that switch in the very beginning. I missed that adrenaline rush. But let me tell you, prevention is very, very rewarding. And since I practice now for 2 years with Dr. Amy next to her, seeing patients, seeing how people improve with their risks is absolutely almost like equally an adrenaline rush because when I was before, I cannot tell you how many times we had patients who came back for the second time, for the third time, and you were thinking, my gosh, can't we do anything to stop this from happening again? Mm-hmm. And so seeing people making that incredible, progress with the prevention, for me, I thought, I couldn't believe it. I didn't know people could actually have an impact, because all I saw was people coming back for the second and third time. I said, and then I come here, I work here, I can see it is possible to have an impact. It is doable. People have it in their hands. They haven't, they can do it. And I witness this every time I see a patient again. I look at their numbers, they look at their lifestyle changes, they look at their dental, issues, they look at their obstructive sleep apnea. It's tremendously rewarding, Gina. I mean, now it'd be the same adrenaline rush and having those, those relatives' eyes starting to tear when I tell them, their loved one is doing fine, but seeing that it is possible, it is tremendously rewarding. Furthermore, for me, I've always been a scientist. I published a lot of articles in the past, and I work here with science. This is a scientifically based approach. It's not some mud that Dr. Bale and Amy concocted. No, everything that it is being done is done because of literature, of science, and of course they've been doing it for 20 plus years, and they have the experience that it's work. Otherwise, they wouldn't be doing it, obviously. So, yes. So it is. It also that the patients are wonderful people, and I have time to talk to them, and I have time to listen to them. Before, it was almost impossible to do any prevention. I wish I could have, but I had to see the next patient who was about to have a heart attack. And so it's a whole different field. But the bottom line is, absolutely, I love the job. Why? Because I can see firsthand how it is possible to. Many people see that they're going to have huge benefit 20 years from now. If they continue with this approach, they will unlikely end up with that, with that stent, and that's our goal. And as you know, Gina, this is what we see every day. People are actually doing much, much better.
Right.
Very rewarding.
And don't you think it's exciting, Dr. Leimgruber, that we have objective ways to measure improvement now? It's not like we can say you look better, you've lost weight, or wow, you can run 2 miles now, not just 1. But we're looking at lab data. We're looking at the wall of the artery. And so when someone's lab data looks scary, because we know now what scary lab work looks like, meaning they're at risk for a heart attack or stroke in the near term, the long term, and we see that markedly improve, as well as year to year see the artery wall actually getting healthier, so arresting and reversing that what can be an aggressive disease process, vascular disease, atherosclerosis, or plaque, if you will. It's an objective thing, so it's not maybe as dramatic on the page as those restoring blood flow angiogram films like you showed us. But I get as excited about it when I'm in the room with the patient. Sometimes they even look at me a little bit funny, but I mean, it's cheers and hugs, and because that's life-saving work. It really is.
There's a good reason, in my opinion, and I'm sure yours too, as to why the Bale-Deneen method works. It's not, it's very meticulous. It's a very discrete approach that the focus, of course, is, like you say, we have to find out if you have plaque or not. If you have plaque, your risk for the problem will substantially increase, and that requires urgent attention. And yes, we do, blood tests. We actually, numbers will show how well you do. You can't hide it. If you do your blood test, it will show how well you did with exercise and diet. Mm-hmm. It will show if you have ongoing inflammation, in your body. And if you do have that, we have to look and do detective work from head to toe, to your gums, to your guts, to your everywhere. All those risk factors that we know have an influence, those root causes, as we call it in the Bale-Deneen method. Once you do it methodically like this, that's when the results will show. It's not, and like you said, oh, you look good, your blood pressure is good, make sure you exercise, I'll see you in a year. Nothing is going to happen at that moment. We know that, but with this very close monitoring approach and looking at what's going on with your atherosclerotic process, it does show the results are there. Mm-hmm. No question. Yeah.
Wow. Well, mm-hmm. I can imagine that your work before was up early, rounding, and there at the hospital till late and long hours, and your job now is very different. Compare and contrast for us just a little bit about the difference in the work environment, your day-to-day activities, and anything else that you think we would find interesting about such a dramatic career change.
Absolutely. Like you said, I enjoyed my work before every day. I never mm-hmm. really, hated to go to work. Some days you were more tired than others, but I always found something enjoyable at the end of the day, in spite of all the work. But I also have to say, the focus was 100% different. The focus before was clearly, I got to make sure patients do not have a heart attack in terms of a stent. I had to make sure the blood flow is maintained in the heart arteries. it's very busy. You know, today the cardiologists, they see many patients. They need help. They have nurse practitioners, as you know, and it requires a huge team. And as I told you before, I had people who came back second, third, and fourth, and sometimes more times. And so here I would think, I got to try, see if I can prevent this from happening. Well, when you see a patient with 5 problems, they have heart failure, they have atrial fibrillation, irregular heart rhythm, you know, they have high blood pressure, they have high cholesterol and whatnot. And at the end of the 15 minutes visit, you have to talk about prevention. You can imagine which section of that 50 minutes took precedent. It was the one about, do you need a stent or you don't need a stent? So you're focusing on intervention. You really did not have time, you know, to really practice prevention. You know, prevention is not something that we expect the interventional cardiologist necessarily to do. What I expect the interventional cardiologist to do is get that stent in as quickly as possible and get that patient out of the cath lab and prevent him from having a lot of heart damage. And that's what they do well. Prevention, it would be nice, but it's not practically to expect to have a regular busy cardiologist to be successful in the prevention field. You know, so that is the big contrast. Now I'm completely focusing on prevention. I have a time to listen to a patient, I have time to talk to a patient, time to educate the patient, time to go to the lab results one by one, time to sketch out a plan at the end of the visit. What is your next step? What do we expect when you come back? What are you going to tell me you're going to do differently, if so? Or maybe you're going to continue to do the same thing because you're doing it well, you know? So that opportunity to be participating and seeing these patients' eye lit up, you know, when they come back with their beautiful results and how they were able to beat it, and you know their risk is getting better, and that is the difference between now and before. Before it was the adrenaline rush, and now it's the prevention. And Gina, I really feel that it's a complementary approach. You know, if we want to really help patient, we have to prevent the problems. Can we prevent on every one problems? Probably not now, maybe in 10, 20 years, probably. So that's why we need interventional folks. We need the preventive folks. You know, we really should be working side by side, and everybody should accept that each other's skills and use them appropriately to get the best bang for the buck. Not everybody has to do everything. You don't know, you know, not everybody has to be, you know, and that's why we have obstetricians to deliver babies, you know, even though a doctor used to deliver those. Nowadays they don't. There's only specialists to do it. And I think the prevention specialist is the one that should really focus on that and take the time to do it and not expect to do a stent. We want him to do prevention and vice versa. Do you know what I mean?
Absolutely. You know, we have a few cardiologists practicing the Beldonin method now, totally into prevention. And we have several that are certainly supportive of it. I know in Texas, the cardiology group, the interventional cardiology group, has been my biggest referral source. Is there any messages like that or others that you would give to your former colleagues at the hospital?
I'm very excited to see that, you know, cardiologists are taking on the prevention field, you know, and I think what you just told me about in Texas, the group that refers you, that is the perfect situation. You know, they recognize your skills, you know, they recognize what you can add to the bottom line, and ultimately the patient is the one that benefits. So the ones that switching from cardiology to prevention, you know, if they can do that full time, it's fantastic because they have the knowledge. They know what the background will be if somebody doesn't do prevention. So they have a clearly advantage, like I do. You know, if I tell patients, you know, if you don't do this, I mean, I can tell you what it's going to look like 10 years from now. So yes, so that's encouraging to see cardiologists. But also, I think what you just said there about the group in Texas, that's clearly the message. You know, we need to work together. We need the team approach. You know, if you can do better with prevention, have at it. You know, you take care of my patients. I'm the cardiologist who watches their blood flow. You know, if you can prevent that blood flow from occurring in the first place or stabilizing, and you know better than I do, I want you to do it. And, you know, and that's the way it should be. And I believe strongly in my heart that that's the goal that we will achieve and eventually will accomplish as well.
Mhm.
So,
I agree. Very exciting. Well, Dr. Leimgruber, thank you so much for being with us today. Your message was so important and well presented. And I know we have several topics for upcoming shows, so you'll be back on. And I appreciate it so much. Any other topics or anything else you'd like to touch on, or is that good for our history of and your transition?
the history, I think this whole field is absolutely exploding. You know, there's so many new areas that Dr. Bale and Dr. Amy always talk about every month in their scientific updates, which is absolutely fascinating. And that kind of commitment that they have, that they provide us with the latest. I mean, every month you think, oh, I need to learn more about Alzheimer's. I need to learn about dementia. I need to learn more about periodontal disease. Oh, I need to know more about the gut biomes. I need to know more about obstructive sleep apnea. I mean, this is absolutely an exciting field. I mean, I don't think you're going to run out of topics, you know, for your podcast, I'm sure. And I'm glad to help you out and as one more come down the pike. But it was a pleasure to be able to talk to you and the folks that will be listening. And I'm certainly available for anybody to have questions, sending it my way for sure. Gina.
Oh, thank you so much. I appreciate that. The comments that you just made me think of your article that you spoke about earlier, is cardiology flatlining. You know, I would say no, but it's only if you are a preventional cardiologist or a preventionist that it's not flatlining, because a lot of people think it's boring. I am thrilled to go to work every day, and it's so exciting, as you've just articulated there, to hear those scientific updates, because the data is coming out on a daily basis, and every month there's more incredibly great studies on prevention and how we can do our job better and save more lives than Dr. Bale or Dr. Doneen can fit into an hour scientific session. So it is very exciting. And I get that same, when we all get together and we do talk about our practices and how to take better care of patients, etc. It is that same atmosphere, as you, if you will, and you probably experienced this too, as it was back in the 1980s, when we were like, yay, we've got stents coming. I can't wait till they're no longer under an investigational study only, but available to everyone, because it's going to save lives. And, you know, I was thrilled to be on the scene about the same time as you, out of nursing school, going through the critical care internship at Baylor. And I'm like, I want to be in the cath lab. I want to save lives. And then you're right. After a while, it's like, after 20 years of that, yes, okay, we're saving lives, certainly in the acute setting when they present with a heart attack, but then they come back again and again and again. And what can we do to keep them from coming back and having more and more procedures? And that first procedure oftentimes is the beginning of the end of and a life of multiple readmissions to the hospital. So, and then now we know we can keep that from happening with the Bale-Doneen method, as well as then people that are even incredibly high risk because of what maybe they've seen their parents or their grandparents go through. They say, I never want to go through it in the first place. We know that we can prevent that the first time. So I don't think cardiology is flatlining, but you got to move over to prevention.
Absolutely, and that's exactly what it is. We have to dig deeper and deeper and deeper and be learning more and more and more. If you just stay on the surface, you will realize maybe it is flatlining, but as you dig deeper, you realize it's a whole new world that opens up. And that's where we need to dig in, and that's where we're going to have an impact. On the surface, it may be flat, but it's a lot more exciting down below. And that's why it's so exciting to be in prevention. That's where it's at.
That's where it's at. That's right. Well, thank you so much.
All right. Thank you, Gina.
Bye-bye.